Welcome to today's conference. The conference follows on from a publication of this very successful book by two pioneers in this field, Susan and Marcus Evans. And it's a intense day of talks and discussions about this rather controversial area of clinical work. The title of the conference is Gender Dysphoria, a therapeutic model for working with children, adolescents, and young adults. And I think our two speakers, main speakers today, have done more than anybody else, I think, including David Bell, of course, to bring thinking, psychoanalytical thinking back into this area. And so I'm really looking forward to today's conference. I'm so glad that it's so well attended. We have up to nearly 400 people. So that is testimony, I think, to the interest and some of the anxiety that this area causes us clinicians when we're asked to think about these rather concrete manifestations of the unconscious, as some of us would say. So without further ado, people are still joining us, but I'm going to introduce our two main speakers for today. As I say, two pioneering clinicians from the Tavistock who have put their heads above the parapet and began to demonstrate that this area is possible to think about rather than be too persuaded by more political, concrete manifestations of theory. The first speaker, one of the first speakers, is Susan Evans, a psychoanalytical psychotherapist. She trained as a state general and then a psychiatric nurse and worked for nearly 40 years in NHS in a variety of mental health services, including the National Gender Identity Service for Children. She now has a private practice in London and she's a member of the British Psychotherapy Foundation, the London Psychoanalytical Service, the London Psychoanalytical Psychotherapy Service, and is registered with the British Psychoanalytical Council. Marcus Evans, whom many of you will know, is a psychoanalyst with the British Psychoanalytical Society. He worked as a nurse in the mental health services and as an adult psychotherapist in the NHS for 40 years. For several years, he was clinical lead of the adult and adolescent department at the Tavistock and Portland NHS Foundation Trust and head of nursing in the trust for 20 years. He's author of Making Room for Madness in Mental Health and Psychoanalytical Thinking in Mental Health Settings. I'm David Morgan. I'm a psychoanalyst and I'm just sharing for today. As well as Sue and Marcus, we're going to have three other discussants from the field. Dr. Susan Matthews, a cultural historian who has written on histories of gender and sexuality. She became involved in this area as she has seen a relative suffer gender dysphoria. She has published recently on the rise of gender identity theory in two Brunstall, Evans and Moore collections. Dr. Kirsty Entwistle is a clinical psychologist from the UK, currently living in Portugal. She is registered as a psychologist in the UK and in Portugal and works with mostly adolescent clients who are questioning their gender. And our last discussant is Stella O'Malley, who's a psychotherapist, best-selling author and public speaker, and a parent with many years' experience working in counselling and psychotherapy with gender dysphoric children. She also coordinates parent support groups. So we have a very interesting discussion group. And also, I think our attendees today bring some real expertise and professionalism to this area. So I'm looking forward to a really good discussion. And I like to create an atmosphere where people feel they can come online and talk to us as best as we can in this Zoom modality that we're all currently still restricted to. So I'll hand over now to Marcus and Sue, who are going to kick off for us. And this bit of the talk is called What Has Happened Here? Okay, an introduction to the area and what has actually happened in this area. Over to Marcus and Sue.
Okay, well, thank you very much for joining us today. So as you're aware, today is going to be a conference that really focuses on the clinical aspects as much as we can. We want to explore those areas today and try and think together with you about what is going on with young people. So it's, as you are probably aware, this is an area of health care that has changed hugely, and it is still evolving. It's changing all the time. Some of you today will be very new to this, and I think some of you are very experienced. So forgive us a bit if we're teaching you to suck eggs, but I think for the people who are newer to this area, what we wanted to do in this first session was just to really paint a picture of what has been going on, sort of socially, politically, as well as clinically, to try and then set the scene for how we're going to look at the theoretical aspects of it, and also the sort of challenges for professionals and clinicians working in the area. The aim of the day, hopefully, is to encourage more therapists to feel that they can work with young people who have gender dysphoria or gender identity issues. And so that's kind of really where we're starting with this first session.
Because a lot of people that we talk to are intimidated by the environment. So a lot of experienced people, so that often the people with gender dysphoria are working with people who sort of maybe not so experienced, and that's a bit of a problem. So we're trying to get, all clinicians, but a lot of the experienced clinicians who sort of stayed away because it's a political hot potato. In actual fact, these presentation, there's nothing very new in it. It's new in terms of what's going on culturally at the moment, but actually, the sort of problems of adolescents getting in sort of fixed states of mind about what their problem is and what the solution is a very age-old problem that clinicians throughout the ages would be familiar with.
So, okay, so we're going to put some slides up just really as to sort of keep us on track, because we've got a lot to get through. And of course, we'll briefly touch on some aspects that we'll be returning to later. But of course, if there's anything, if you send a message or a question in, we'll try and get back to that later. So first of all, what is gender dysphoria? Well, that's hotly debated as well, but essentially it's a sense of distress, a feeling of discomfort between the sexed body, the biological body, and the gender identity. There's a sort of mismatch feeling. One of the important things to say is this is something, the categorization of this is one of the areas straight away where you see this evolving, changing, and I think politically pressured change in what should be a clinical area. Of course, we're always reviewing mental health in psychiatry, the DSM, the ICD. They're always sort of renewing and looking again at categorizations and diagnoses. But I think the important thing about this to say is it used to be considered a disorder, gender identity disorder. And in fact, shortly before I went to work at the Gender Identity Development Clinic, it did have the title of disorder in its name. But I think that was in 2000. Well, it was back in the 1990s that started to change. But I went to the clinic in 2003. So then and gradually over this past decade or so, there have been changes made in the categories in the DSM, and I think even upcoming the next ICD is going to change gender dysphoria, I understand, to gender variance. Now, I think, with all areas of mental illness, what's happened over the past few decades is there has been an attempt to destigmatize mental illness and to make it okay for people to talk about mental health issues. And I think that's absolutely right. I think there's a bit of a trend going on in this area, which is a sense that they're trying in some areas to disaggregate the idea of gender dysphoria, which is a mental distress, from anything really connected with the psychology of the person, the sort of emotional world of the person. And, in our view, and certainly in the work that we're doing and have done in the past, our view is that there is always a lot to look at in terms of a young person who comes and presents with these experiences.
I was going to say, I think some time ago you were at a conference where I think Lord Alderdice said, I might be wrong, but someone very significant said, in actual fact, this conference, which is about gender dysphoria, shouldn't actually be at the Tavistock, which is a mental health trust. So you could feel that was a long time ago that was said. There's this sort of political pressure to take to sort of disaggregate, as you say, the idea this is a psychological condition, as if it was some sort of choice in a way that is not affected by the individual psychological state. And although, as Sue said, stigmatization is unhelpful, it's also unhelpful to sort of say, look, there isn't a psychological issue to in terms of what's going on here. That's very important. We've got to think the mind has got to be looked at before we make changes to the body.
Yeah.
Mm. Okay, I think it was Lord Carlisle.
Oh,
actually,
cool,
we
right,
don't want to lord out of that.
Sorry about that.
So, okay. So, and I think that's sort of perhaps in a sense the most important aspect of this, that whilst a diagnosis can be helpful in a sense in terms of knowing the ballpark area of where you are. And of course, there are very definitely signs and symptoms of gender dysphoria. But it's also important to know that it shouldn't be disaggregated from the sort of the whole person. One of the things you will hear about gaining a diagnosis of gender dysphoria is that there are these things called consistence, persistence, and insistence. And I often have heard these talked about, and of course they're there in a sense in the presentation. But again, what we will talk about later on is that actually the fixed state of mind that would create this insistence and persistence, a sort of rigidity about ideas, actually is one of the very things that I think young people need to be helped with, and it needs to be looked at as part of the presentation. So you'll see that we've mentioned the high incidence of comorbid problems. And again, we're going to come back to that later. But it's really just very important to say that almost all the young children, certainly that I've encountered, whatever their ultimate choice is, and this goes for young adults as well that I've worked with, is that I think that there are issues that they're trying to manage and deal with and defend against in their mind, that whatever their future decisions about whether they transition or not, it's really helpful, I think, to explore and understand and try and help the person sort of come to terms with some of those issues that are sort of perhaps forcing them along this route, and to kind of have these ideas about themselves. And it's not that in the end they may have those ideas, but the idea is in doing this sort of assessment work and exploratory work, is that then they may be in a better position really to understand their motivations and their sort of unconscious motivations particularly, which I think can be helpful. So, and again, I keep saying we're going to come back to this, but we're just flagging up that our view is, and anyone who started looking at the book will see that what we feel is that there are kind of, perhaps the children who are presenting with this have often had sort of early traumas, and by that we don't necessarily mean gross traumas. They can be sort of unseen traumas, in sense of the more obvious ones might be the serious illness of a sibling or the death of a sibling, parental depression or parental mental illness, separations, early separations between the child and the parent, but also more subtle difficulties that might go on. And again, we'll come back to that. But I think that it's important to say that it's about, in our view, a difficulty in adjusting to the demands of development. And of course, one of the things that has gone on more recently is that there's been a huge change in the category of, or the cohort of the young people coming into the service. It used to tend to be younger boys, and they would sort of often persist right through their adolescence and into adulthood. What's happened more recently is there has been a much higher number, firstly, of referrals and people presenting with transgender identity to their clinicians, but also it has rather moved into adolescent young females as the larger group of that. And what we're beginning to think about here today is the difficulties that some of the children, particularly the adolescents, are having in adjusting to the demands of development. And we'll come back to look at that as well. Is there anything, were you going to say something
I was just going to say a couple of things, and this has happened in not just in this area, but also in mental health generally, and that is the tendency to divide people up, so that sometimes, you know, people can be referred to the gender service, and it's as if the fact that they're socially isolated or maybe on the autistic spectrum, there's an idea that that can be dealt with elsewhere, as if it's nothing to do with the presentation of gender dysphoria. That actually, as Sue said, you know, we got to think about the fact that we're complicated as people, and that we've got lots of different moving parts, and they all relate in a sort of dynamic relation to one another. So you can't take out something called someone's gender disorder and split it off from the wider aspects of the personality. You know, you've got to look at the kid and the family as a whole. The other thing that I just wanted to sort of follow up on, Sue, is that obviously, you know, the dynamics going on within the family are important and should be part of a thorough assessment of why the kid presents. But as we all know as parents, you know, this is not to sort of say, you know, it's the parents' fault or whatever. Kids have got their own genetic inheritance, and they react differently to different situations, and that's got to be taken into consideration. So when Sue talks about the fact that some children are traumatized by sort of things which other people might think are not traumatic, you know, first day at school, some kids are sort of screaming, "Mummy, mummy, don't leave me." Other kids are sort of bouncing into into school. So, you know, as individuals, we've all got our innate sort of characteristics. It's a bit of nurture and nature. It's both together. Sorry.
Okay, we'll move on to the next slide. So okay, as I've already mentioned there, the changes in the clinical profile, and it's worth just mentioning in the States, Lisa Lippman produced a paper where she talked about the idea of this rapid onset gender dysphoria in adolescence, and you know, it was hotly debated and it's still a contentious issue. But I think what we cannot deny as clinicians, certainly who were working in this area, and I think it's internationally recognised, is that the clinical profile has changed, and it is no longer just the sort of younger boys who are presenting with gender dysphoria. So, and I've talked a bit about the politicisation of the clinical environment. I think the thing to say is that even when I worked in the gender identity service back in 2003, I was aware that it felt, excuse me, very different to any other clinical area I'd worked in, and I'd worked in the NHS for a very long time. There seemed to be a way in which external factors and sort of charities and groups had an influence on the clinical environment. So in other words, normally in certainly at the Tavistock clinic where we were working, anything would be open for discussion, and there would always be questions asked. There would always be a way in which one wanted to look more closely and debate and even disagree with one another. What seemed to happen in this area was the message seemed to be coming from outside, that we should follow a certain pattern, we should behave in a certain way. And I think that this is increased, and it's something I'll come to shortly. So the other point there is the lack of outcome research. How much? Right. So firstly, back in 2003, again, when I was working at the gender unit, I became concerned that some of the children were being progressed too swiftly to puberty blockers. I saw people go after 4 sessions. And when I looked at the children that I was assessing, I felt there were, quite complicated backgrounds and a lot of work to do to try and understand what was going on in the presentation of the child. And I think we asked, well, certainly I whistleblew, and we asked for a review, and somebody named Dr. David Taylor did a review in 2006. He gave his outcomes to the senior management team and the board at the Tavistock. One of the leading messages there was that he could see that there wasn't enough research and there wasn't enough evidence for the model of placing children on puberty blockers. We also didn't really have any longer term follow-up. And so that was one area. He felt that there needed to be a lot more research into the area and a lot more understanding of the various treatments that were on offer at the clinic. This has persisted, and although one will find all sorts of people claiming that there's good research to evidence this or that, in fact, what we have begun to see is that most of this treatment model was based on one research. It was called the Dutch protocol. This was done on a small number of boys. I think it was under 60 boys. Most of them had been that earlier presentation.
20 dropped out.
Yes, I think there were 70 originally and 20 dropped out. But what happened was that the whole of the world effectively started to use the Dutch protocol as the kind of go-to model. And of course, the children that are coming into the services now, if as we see, and they're not just young women, young girls, teenage girls, they are also teenage boys as well, who are coming in greater numbers in adolescence. So the problem is you've got only one small piece of research outcome that is being applied to a whole new cohort. The other thing to say is that unfortunately statistics always get used in a way that suits the person who's trying to put a particular message across. The truth is there is a real lack of evidence base to the medical model in the treatment of children. And even the Tavistock research that was printed recently states that really there is very little to say that this is a positive model that is being used.
I was just going to say that that astoundingly, as David said, I used to be in charge of the adult and adolescent department, and that I had to produce 3 monthly reports for the commissioners on epidemiology, who was presenting, what their diagnosis was, and that would go for right throughout the clinic. You've got to produce these reports, but amazingly, and I think this is to do with the political pressure. There are no outcomes for the GIDS kids. They don't know what happens to them. It's quite extraordinary that a vulnerable group with an experimental medical approach is not followed up. So it just goes to show what a strange world we're living in.
And in fact, you even had that experience when you worked at King's, where you did the parent-suicide liaison service, didn't you?
Well, the thing is, I think you're going to come on to say, there's a lot of quotes put out about this area, claims made, for instance, the incidence of suicidality. Now, one thing that was said, so I used to run the para-suicide service at King's in the early 90s. Now, one thing that was said then, and as Sue said, it was a very different cohort. It was mainly adult male to female transitions. The sort of thing that was sort of bandied about in psychiatry at the time was that everybody who goes through the sort of Charing Cross program made a good adjustment after, a transition. The fact is, I used to see a number of people who may have had pre-existing problems. They then had gender reassignment surgery. The belief was that they were going to have their problems sorted out. They then, the following months and years, realized that actually they're the same person, and that they would then become suicidal, and they'd be presented in King's and I would see them. So now that I used to see a sort of steady throughput of people for whom transition had not worked. And that was in the early 90s. Now, the thing to go on to say is there's been this exponential rise in presentation of gender dysphoria and people wishing to transition. The age range has gone down and down and down. And you've had this reverse of it was mainly males to females. For the first 30 years of my time in psychiatry, the last 15 years, there's been a sort of reversal. And the other interesting thing to say is nobody seems really interested. The Tavistock had a long history of doing sociological research. You know, what on earth is going on? And there was a reluctance to really sort of look at this and question it.
Mm.
Yeah.
Okay, so I think we've covered that slide there. We sort of
the challenge. Because you want to say something about
I've said something about that. I mean, just the challenge of clinical discussion is, as I've said, that I felt certainly when I worked in the area that I tried to raise concerns within the team, and it felt uncomfortable. And I know that Kirsty, who's joined us today, Kirsty Entwistle, had a very similar experience. She was in the team much more recently. And, you know, if you have clinical concerns in other areas, it's always something I think we have a duty to raise them and to talk about them as clinicians and to ensure that we are doing our best by our patients in doing so. And I think in this area particularly, there are child safeguarding issues which should make it actually imperative that concerns should be raised. And I think that it felt very uncomfortable. And I was aware at this conference that I attended, you know, that it even within the conference, I ended the day with a terrible headache, feeling I'm not sure we can really explore this area. And yet it seems an area that it's so crucial to explore and understand, because none of us really knows. None of us know yet what is going on here.
Yeah.
We've got our ideas and other people have theirs. But as yet, there is no clear picture. No expert can say this is it. And so, you know, I think we have a duty to discuss what is going on. And that seems to be closed down and again. And to be called transphobic when actually what one's trying to do is understand, it's not helpful. Time and again, it's something I say that, you know, our aim is to open up and explore and give better treatment in this area so that hopefully whatever the outcome, people feel they know themselves more.
The thing is, isn't it, is that medicine moves on by clinical challenge. And you always got to look at, there's always a downside of treatment. And there'll be a downside of our approach and arguments against. That's how you understand the presentation better. But if you sort of negate all challenge, you just end up with a sort of doctrine that everyone either buys into or is felt to be in opposition to. It's just not helpful.
So, okay, so this again, some of you will know this very well, but I just thought we'd kind of go through these fairly quickly and we can come back if people want to ask more questions. There's this thing called the affirmative approach. And as I say, the sort of fashion, if you like, in psychology and psychiatry and mental health work and in schools and now in society is to use this affirmative approach. Now, I think it came from a good place, and I think it comes from a place that psychoanalysis sits itself in, which is when someone comes to you and tells you something, you are open to what they're saying. You take it in, you take it seriously, and you treat their sort of their feelings with care, and then you start to explore and try and understand together what's going on. There's no aim to have an outcome. It's just to sort of go on a journey together of understanding. The affirmative approach takes the view that as soon as a child states they think they are transgender, one should affirm that and agree with that. And if they want name changes, pronoun changes, one fits in with that in order to make them feel better and supported. And I think when one sort of disputes the whether this is a valid approach, one just gets accused of cruelty and how could you take away a child's autonomy and they should know. But I think, again, if you've worked in the area, and certainly if you work with young children and adolescents, their minds change a lot. They develop a lot. They aren't often certain about anything. They will feel it at the time, but actually it's a process of development into adulthood. So
and certainty can be a problem.
Yes.
I mean, that in a way, if you're making a major change, you would expect to have doubts, anxieties, and that certainty, which is often put forward as the child was certain, as if that was a good thing, whereas in actual fact, one would expect conflicts, anxieties, doubts.
So, and then the memorandum of understanding, and very interestingly, I just did a group with my LPPS group of clinicians in London, and it was interesting that even some of them weren't really aware of what had happened in the area of the memorandum of understanding. And forgive those of you who are international, forgive us, we've become a bit UK orientated, but I think from what I understand, you've got similar agreements going on in your countries as well. But in the UK, we quite rightly, back in the sort of I think it was the sort of 80s, we recognised that conversion therapy for homosexuals was wrong. There was a move, I think largely by sort of religious organisations, to try and convert homosexuals to heterosexuals, and it was recognised that it was very wrong to do, quite rightly, and it was banned as a sort of, some conversion therapy was banned. But the memorandum of understanding more recently, in the last few years, has been reworked to include transgender identity or gender identity. And it was based on the idea that it was sort of LGBT went together. And of course, I think, if you look at this area, there is a way in which you would understand sexual orientation to be something that sort of tends to develop and tends not to change in adult life. Occasionally it does, and again, there's always a flexibility. We feel there's always room for change, but largely that's about a sexual orientation. Whereas what we know in gender identity is people often change, their minds move around, they do go backwards and forwards. And so it seems a strange thing to have said that if one doesn't affirm the young child in their belief that they are transgender, that somehow you're practicing conversion therapy. And I think that there's a way in which it's a sort of slightly upside down view that actually, if you just say to a child, yes, I confirm that you are actually not really a girl, you're really a boy, you've confirmed something that for them might actually change later in life. And the other thing is, you're not trying to convert them if you don't go along with it and confirm it. You're trying to explore with them why they feel that way. The difficulty is that there's a pressure on, and I understand in certain states in Australia, I think, and America, I think this has become, and maybe elsewhere, it's actually become something that therapists can be legally charged with. They can have their licenses removed if they practice this conversion therapy. Now, of course, they shouldn't be practicing something which doesn't sort of offer an understanding to the child. They shouldn't be telling them they're wrong to think it or to be punishing them for feeling that way. But one explores, and that's the whole sort of basis for sort of certainly psychoanalytic and many other therapies, is to have an open mind in which one is going to look with the person at why they feel the way they do, and to try and...
Yeah, I was going to say, it relates to, again, in mental health, you used to say an anorexic wants to starve themselves, and you understand that they feel very distressed when they eat and they put on weight, and it makes them feel worse. One's trying to empathise with that, but without colluding with them that food is poison. You know, you're there to try and understand what that's all about and work with them, not to either collude, nor is it to sort of bang heads particularly. You got to find out what's driving this.
So I'm just going to touch, because I'm aware we're sort of talking a lot here. Perhaps time is running away with us. I don't know, David. Are we still okay for time? So the policy capture of our schools and in our institutions, I know there are other people in our audience today who could talk in much more depth of this, but the reason we've just put it in there to flag it up is, unfortunately, and you may have seen this, there's sort of been a news piece this week about Stonewall sort of asking to remove the name of mother.
Yeah.
And call us the person who gives birth or something similar. So, and I think it maybe has peaked a few institutions, but up till now, there has been a very successful way in which our institutions and schools and so on have been kind of captured by this. And I use that word. It's not that there aren't some good messages within it. Of course, we're trying to develop tolerance to difference and diversity. It's a very good thing. But unfortunately, something rather more political seems to have got into the education of young children in schools. And I think, you know, certainly for young people who are developing, I think that's an unhelpful thing. And we can maybe come back to that in the discussion later on. But it's in there really just to say to therapists and professionals who are trying to work in this area, we absolutely get how difficult it is if your institution is in the grips of a kind of a policy that only uses the affirmative approach. And you know, I'm hoping that in time we find a way to open this out, but you know, it's a really difficult area for some of you who are in that kind of environment at the moment.
So I was going to say, James Kirkup, who's a journalist who's written about this, who basically says in 35 years he's never known how effective certain sort of political groups have become in getting hold of the agenda. I was just going to go back to the affirmative approach, so that before the affirmative approach, and again, there are people, Ken Zucker will know a lot more about the history of this than we do, but there was the watchful waiting, which was the traditional approach, in which there is evidence to say that if you support a kid who's got gender dysphoria over a period of time, they desist. And that sort of policy was jettisoned in preference to the affirmation model, whereby there is evidence to say if you even start to socially transition, you send people on a sort of path that a lot don't get off.
And in fact, I think just to say, going back to my personal experience more recently, many of you will have heard of Kira Bell, who is a detransitioner. And one of the things, you know, that's heartbreaking about her story is that she transitioned very rapidly between the age of about 15 and 20 with hormones and surgeries. And very soon after her mastectomy, she realised that it had been a mistake, and then began to realise that she had all sorts of issues that she needed to understand about herself from her earlier childhood. And she said in an article you know, that she had wished that an adult, and she said this in her witness statement as well, that she wished that an adult had kind of asked her more questions and explored with her and kind of stood up to her idea, because she said, I was one of those persistent, consistent children. She said, I was absolutely certain that it's what I needed to do at the time. And that's something that we hear quite a bit. And when you listen to detransitioners or desisters talk, is that they feel that they were very certain, and yet somehow there was some part of them that would have wanted an adult perhaps to try and say, well, let's try and think about it, rather than simply agree with them. So how does a child consent for treatment? I've written there. So look, one of the things that has happened in the UK, and I think internationally might be known about now, but we'll talk very briefly about it, is that when I was at the Tavistock, as you know, I did whistleblow. And then there was this much more recent case where Dr. David Bell did a report because 10 staff had spoken to him confidentially. And then it came out.
And then there was a letter from, this is when I was the governor, so this is 2018. Then there was a letter from a group of parents whose kids had been seen in the gender services. And what was worrying was between the report that happened in 2006 with David Taylor, David Bell's report, and the letter from the parents, that there was a sort of continuity, and that was that kids with complicated problems were not being thoroughly psychologically investigated. And the fact that I didn't feel the trust would take this seriously, because I was a governor, had to sort of oversee whether the trust was doing its job in relation to these kids. That's why I resigned. And then, important to say, you started the judicial review with Mother A, didn't you?
Yes, but what happened, and then Kira Bell became the other claimant in the case. But I think that the reason we went to court in the end was because, despite concerns raised, and not just by one or two, it was by a considerable number of staff who were actually working in the clinic at the time, there was a real concern about the manner in which children were consenting to this experimental treatment. And the informed consent procedure that was being done with the children was viewed by the staff who were witnessing it as wholly inadequate. And of course, if one thinks about it, you're asking a child potentially at the age of 10 or 11 at Tanner stage 2 in their puberty to take a puberty blocker. They're consenting to a puberty blocker, which if they then go on to a cross-sex hormone treatment a few years later, which at the Tavistock virtually 100% of them did, they have effectively consented to probably making themselves sterile. They have effectively potentially given away sexual pleasure. They won't produce eggs, they won't produce sperm. And there was no way, and I remember the QC who we consulted with, Mother A and I were talking with the QC, and he said, if you were to ask a bus driver, can a 10-year-old child give consent to this adult concept, he would laugh, and I remember thinking, right, we've got the right QC for the case, because I think parents, anyone who's met a child or worked with children, knows that they're on a developmental path and that they are not mature enough. And it's not to say that they won't say yes, and they might have all the information, which is to say, well, you might not be able to have a baby when you're older. That's fine, I don't want one. You might not be able to have sexual pleasure. Do they even know what an orgasm is? So the problem is the language may be changed, but the problem is you're presenting an adult issue to a child of 10 or 11, 12. The Tavistock wouldn't listen to the concerns. They didn't listen to concerns of the parents, who wrote a really good and considered letter. They wouldn't listen to the concerns of the governors. They wouldn't listen to the concerns of the staff working in the unit. And so for that reason, we took the case. We didn't really want to do it. It was a lot of work, and the judges agreed that after they'd looked at all the evidence presented on both sides, and this was in a court, a judicial review, the judges felt that a child under 13 was highly unlikely to be able to understand how to consent to this treatment, and that even children under 16 were most unlikely to be able to consent. They even said that 17 and 18-year-olds, if they had particular comorbidities, might also be in concern, and that clinicians should consider taking them to the family court as well, to have their cases put in front of the judge to decide whether they could go ahead with it.
I was just going to say that some people in the medical profession, they think medicine shouldn't be in the courts. And ordinarily, I think Sue and I would agree, you come to a medical consensus, But the reason that we felt that this had to go to the courts and that Sue started the case with Mother A and then Kira took over was because there's a failure to really look at the evidence of what's going on here. So this is a sort of failure of medicine, and that's why you've got to go to the courts, who would adjudicate and say, is this right?
And Mother A was quite rightly listening to, the news and the radio and reading articles. Her daughter at the time was 15, was very worried about, she's on the waiting list to go to the clinic. And she was really worried about what was going to happen to her daughter, who also had autism. She was worried she would arrive and really not be considered and very quickly might be on a treatment. So for her, it felt particularly pressing. So the implications of the judgment at the moment, again, apologies to our international audience. In the UK, there's currently an embargo on prescribing puberty blockers to new children who come into the clinic. They're not at the moment doing that. The ones who had started, I believe, have been continued on their treatment for the time being. The review, there's an appeal on the 23rd and 24th of this month in the UK, and it really, the implications of the judgment is partly when we first sort of started out in this area, particularly with the case, we agreed that one of the things would be people would feel, well, what are you offering? What are these children and their families going to do? And we thought it was important to offer something into the care of the children. We're not saying it's the only thing or the right one, but we believe that this is an addition, and it certainly holds off doing any harm until we understand this whole area much better. So, and then, so really that's why we feel there's a need for the promotion of the psychological model, because I think a lot of professionals have been intimidated, really, or just mal-educated, can I use that phrase, to believe what they've been told. And I think a lot of parents have been scared into believing the medical model is the right one. And of course, if you go to a gender clinic where the so-called experts say this is the right treatment, I can understand why many parents would feel, right, I'll go along with it. They know what they're talking about. But
parents often contact us very worried. Often they say, look, we don't mind if our child transitions in the long run, but they've got complicated problems. We just feel this is too much of a rush. But often they're made to feel as if they're not on side with the message, and they've got to sort of, keep their reservations to themselves and just back the child's wish to affirm. And we think quite rightly, they're coming to us because they're saying we're just not comfortable with what advice we're being given.
So,
well, I was just going to say, the thing is that Dave Bell picked up one of the things in his report, and I think, and now he's retired, he's free to be involved in the review, which is going to happen. But basically, we thought as Sue said, there have been people who thought about this in the Portman, for example, David, over a long period of time. It's not that there's been no thinking about this area. And Ken Zucker raised this point with us. There have been people who've been working in this area and thinking about it, over a long period of time. But all that knowledge seems to have been sort of left behind. And wrongly left behind. Sometimes the baby chucked out with the bathwater, because sometimes some of the ideas, like with Stoller, were of their age.
Yeah.
But the problem is, it's left a sort of vacuum in terms of psychological understandings, and as we thought that's why we wrote the book, really, as a starting point, because other people will develop these ideas, and we've even started to think. As we get more clinical experience, develop some of the ideas in the book. But good.
Excellent.
I'll stop there, I think, and I feel
okay. Thank you. Excellent. Thank you very much. I mean, what you're talking about really is we see as a countertrans phenomenon. There's not identifying with the need for certainty and addressing the underlying anxiety about thinking. Okay, and it's easier to identify with the certainty and satisfy that rather than challenge it. And the whole book is a relief from that perspective. You actually are beginning to say you can think about these things without going along with the sort of groupthink. You know, Susan Matthews, who I introduced earlier.
Yes.
Yes.
I'm, and you can hear me. Yes. I mean, I really just want to say, you know, thank you to Marcus and Sue for writing this book and doing this work.
Yeah.
And I'm going to sort of put my parent hat on, because, you know, I'm one of these people who came across this issue in my family, and like so many parents, you then suddenly want to become a kind of, you know, and to read absolutely everything you can, because it's such a strange world. And what strikes you is that all of a sudden you don't trust the medical professionals, you don't trust the doctors, you can't trust anyone. But there are now an awful lot of us. I mean, the numbers, of course, are absolutely extraordinary. And, you know, we have new parent groups like the Bayswater Support Group with now sort of around 250 parents. And what really strikes me is the similarities of the stories. So the superficial similarity of the stories. So you have, you know, another parent comes along and tells their story, and okay, it's the 14-year-old daughter, and where we all know the 14-year-old daughter story. So there are these extraordinarily sort of similar stories coming along. Or it might be there's the 14-year-old daughter who maybe a little bit autistic and there's a bit of self-harming. She wonders if she's lesbian. And then she announces she's a boy. Or then there's the 17 or the 18 or the 19-year-old son, and that son probably is very much into anime and loves the comics at Forbidden Planet, and, you know, probably doesn't have all that much sexual experience, and all of a sudden they discover they're a woman. But to the parents' eyes, it comes out of the blue. It's the most bizarre statement you can possibly imagine. So we've got this huge number of parents going, what is happening? And coupled with encountering professionals who are either absolutely terrified of working with gender, who just say, oh no, that's very highly specialized, you know, we wouldn't want to talk about gender, or can only talk about gender, as if gender is the only thing, and as Sue and Marcus said, want to split it off from everything else. So the sort of return to a world in which we can see this bigger picture. And we now have, I think, a lot of people trying to reconstruct the bigger picture, to tell the story, to lose this bizarre cultural amnesia which has come over us, so that we sort of forget everything that's happened over the last 50 years.
Just a couple of questions have come online here, which I think just, you know, covers both ends of the spectrum. Sue and Mark, please advise clinicians who are petrified to even speak about alternatives to affirmation. The intense fear of harassment and loss of livelihoods is visceral. How can we link up and support one another? And do you or others offer clinical supervision? Okay, bit of work there for you. And then the other speaker from the other side, which I think the last person who intervened was covering, the speakers are focusing on people who regret the medical interventions and not the majority of the cases that transition are successful. In most cases, regret is about the heteronormative environment and hostility to trans people. So that covers both sides of the dialogue, I think. Yeah. Put your mute off. That's it.
So basically, the thing is that's the sort of claim that's made. Everybody makes a good transition. Now, the fact is, there are more and more people who are saying they haven't made a good transition. That's the first point. The second point is this is a completely different cohort from, as I said, the first I've been in psychiatry for 40 years. The first 30 years was mainly males past the age of 18, because that was the law, transitioning to female. It's now young children, because the law's been changed and now changed back, mainly female to male. You know, so that you've got to be cautious before embarking on a medical intervention, which will basically, interfere with people's, natural biology. Now, some people, as Sue said, are going to transition. It's not for us, as David was saying, to say what other people should do, how they should live their lives. We all have to make decisions about how we, manage this thing called life, which has got all sorts of bumps and bruises and problems and challenges. The question is as a mental health professional, one wants to feel that there's been serious research, psychological investigation. So before making any life-changing decisions, one's really feel you've gone through a thorough process. So that's the answer to that. In terms of the intimidation that does go on of anybody who raises their head above the parapet, you've got to, people take an individual position about this. But, Sue and I retired from the NHS. We are in a privileged position. We've been around the block. We're sort of quite experienced, and our careers are not going to be affected adversely by speaking out. Younger people who've got their careers in front of them, they're much more vulnerable. So you've got to assess your situation and decide what you're prepared to do. Sometimes I think that you're often finding like-minded colleagues who can sort of support one another in an adverse situation. But as Sue said, it's very difficult because you want to feel that basically your doubts, questions, concerns, thinking is supported and encouraged. You don't want to feel that that's sort of against the culture. But as I say, countercultures do exist, and one can find like-minded people who you can have a chat with, sometimes in private, and gather strength that way and think about how you might tackle things in a broader way. But I'd be cautious.
Yeah.
Susan, I was just wondering whether your last point there that you were about to make was connected with that, really, about the sort of clinical. Go on.
No, sorry, I'm sort of butting in, but I thought you made some really important points. There's a lot of sort of tuition that goes on. I was thinking about your point about how, and Dave Bell makes the same point as a result of his interviewing the concerned clinicians at GIDS, which is often the stories that are presented very similar, and that there's quite a bit of tuition that goes on online. So that you're not really seeing the kid as they are, the child as they are. You're seeing a sort of, they've learned what boxes to tick, and a good clinician's, as their skepticism, say, well, hang on a minute, this all sounds a bit formulaic. The second thing I was thinking about was a point that I made on the Today programme, was that the trust about, the sort of the claims of the experts, the trust keep using this thing that they say, our world-class service, see, and it's to just shut down dissent. For me, a world-class service would have thorough research, would look at the downside. There are well-known things that clinical services do in order to claim the badge of world-class. And I do not think that GIDS fits that bill. It is purely used to shut you down. And the last point was that a mother phoned me, and a friend of the family had said, would you speak to this parent? She's a very opinionated, quite confident woman, and she's a researcher, whatever. And what she conveyed was how intimidated she felt. She felt she completely lost her confidence when she'd been told she was wrong to be concerned about her daughter's wish to transition. So it's sort of this claim of expertise is often used to make the other feel like they don't know what they're talking about. And again, this is very damaging. This is a very toxic environment. Sorry.
Absolutely. That point about the similarity of the stories is very striking. And it's something that we parents see talking to each other. But it's also something that's in the literature. I think Kantiala Haino talks about a class of kids who turned up in the clinic in Finland, and they all told the same story, and they were the group who all told the story about having a fantasy of wanting to be a wolf in the forest. So bizarre similarities, quite uncanny similarities. There's a sort of loss of individuality and complexity, and I think that if you can return that individuality and complexity and let the person realize the complexity, the young person realize all their different interests rather than this narrowing down onto a single focus, and allow the complexity of the family stories to emerge. And I think, of course, one of the things that is often said about the psychoanalytic approach is that it's pathologizing, and that it's difficult for parents because it makes them feel that they might have done something wrong. And I think that is an issue. And I think it's understandable that for a parent, it's very attractive to be told, well, there's nothing that's gone wrong in your family. You've just got a special child. And we do all have special children, and all our children, are perfect in their own way, even if they go through periods of trouble. So I think to sort of produce an atmosphere in which it's possible for people to reveal the complexity without feeling terrified is I don't know quite how you do it, but it's a sort of important thing, and you all know how.
Thank you. Yeah, we've got a few questions coming in, and somebody's got their hand up, so we throw it open a bit more now. From Francis Lampert, a question for the speakers: if those who are given puberty blockers so frequently go on to inevitably have a more permanent physical transition, is there some need for more pause for thought, psychological interventions at that stage?
Really, that's really what we're going to talk about today, because as I've said earlier, that there's a complexity, I think, to many of these young children who present, and I think you're doing them a disservice if you don't look at them holistically and give them, a good assessment and a period of time to try and understand why they feel the way they they do.
Yeah,
and this might be.
Go on, John.
No, well, the important thing, and it's a shame, that the first sort of question, in a sense, sort of rather sort of said, well, I thought this was clinical, but go and look at the evidence. Really, what we're trying to do today is, we're not saying, oh, this is the only way, but we're saying, here's a way in which you can open up a discussion with young people, see whether or not there's a way in which you can help them explore things. And certainly in our experience, and I know in some of the other people who are listening in today and here as our discussants, that's the experience we've had, that if you give young people an opportunity to explore more, they then actually find a bit more of themselves. Very often the way in which they've been relating to themselves and the external world changes, it develops, and I don't know why there's such antipathy to that idea, and it's not to say that as they get older they make their decisions, and we would as much support someone going on to transition as we would someone who's detransitioned. That's
Thank you. Julia says, I'll come on to you now, Milton, but Julia says, we as clinicians come at this subject from our own beliefs, some believing it is possible to be literally born in the wrong body, and therefore believing children need medical treatment to realign their bodies with their true gender identity, and others believing that some children have gender dysphoria, leading to feeling distress about their gender identity, requiring therapeutic approaches. How can we as services work effectively with children with gender issues when staff have such different views, leading to differing outcomes?
It's a very important point, and we all rely on beliefs. We all have a sort of, it's the way we operate in the world, isn't it? We would like to have a certain viewpoint from which we view the world, but beliefs, one of the important things about sort of maturity is to know that one's beliefs can be misguided, and one's one wants a situation in which your beliefs can be relinquished, particularly in the face of experience or the evidence, so that we have beliefs, we need them, we endorse them, but if we're open-minded and that our experience doesn't match the beliefs, there comes a time for relinquishing them. Now, as you say, in the current environment, it's the first person who brought up the question: how do you hold on to your beliefs when you're in an environment which basically outlaws your thinking? Now, to me, that is no longer a clinical environment. The clinical environment is one in which we can look at our own way of thinking from another point of view and be prepared to discard it.
Just one more from Laura Palacio. I would like to share what I thought was a brilliant description of a young person I'm working with. She is born female, 14, and struggling to find herself in her new changing body. She is clear she does not know how she identifies, but does not want to explore it openly because she fears she would then be pressurized socially to follow a transition path. We're exploring this in treatment where she feels slightly safer to change her mind. She cut her hair last year, and the first reactions at school re her hair were asking her if she wanted to change pronouns from peers and teachers. So Laura then illustrating beautifully, I think, the capacity to try and stay with uncertainty. People are allowed to be in an uncertain state, okay, from clinician and more activist ways of thinking. Okay.
The thing is that puberty is so important in terms of this, isn't it?
Yeah.
You know, you're growing up, you're sort of a child, you're in a particular position, and then all of a sudden puberty enters the scene, and it causes a disruption. It's sort of opening up, you know, the transition from childhood to adulthood. There are all sorts of questions about sexuality. People feel disturbed by the changes in their bodies, etc. And you see, in a way, the puberty blockers go along with a sort of a wish that, you know, that the apple cart has been disturbed, and in a way you want to put a lid on it, as if to stop the confusion and anxiety that's provoked. But actually, one's got to sort of, hold the line over that. We think adolescence should be a rather confusing process. It's not to say a lot of us would say our adolescence wasn't that great because we didn't know who we were or what we were doing or what role we were going to play. All sorts of anxieties about our, sexually, how you're going to perform and all the rest of it. But in a way, as adults, we sort of stand by and allow that confusion to take place. Not in a sadistic way, I don't mean that, but sort of understanding this is part, Sue said, of the developmental process. Let's see how this kid works these things out. Not put a lid on it.
Okay. Milton Sattler. Sorry to keep you waiting so long.
Oh, no problem. Thank you. I have to read something that's, I made some notes. I think first, we are, I assume the majority of we are not doctors or come from a medical field. We are therapists. The children that's got the GID clinics, they going through a trolley process until they being assigned to a medical intervention. Is known. I think this is the role. There is a division between what's the medical intervention is going to happen and how therapists is going to help in these children. The other thing, the MOU, the Memorandum of Understanding 2, which is in the UK, doesn't stop therapists to work with clients that question on the sexuality. They is all open to exploration. It's different. I know there is a lot of concern, and I think there is a lot of concern in the psychoanalytic world that being in the past very pathologized with LGBT people, and now still quite a lot of resistance to accept trans people to be who they are, I think. And I think I don't think it's brave to be here and have this discussion without to have the other side, other speakers that's think in a different way. It seems so far all these speakers have the same kind of understanding about gender dysphoria, which is, in my understanding, what I'm being here, that's, or you cannot help kids because they too young to have a concept. I have worked.
Yeah.
Sorry.
Thank you. I just let the speakers respond a bit now. Although
Okay.
It's a bit long. Okay. Thanks, Milton.
I mean, look, we get attacked on a regular basis for the stand that we've taken, and that we've discovered that actually having a sort of dialogue, which is normally what I would do, would be the normal course of events in a sort of clinical. You know, my interest has been in the application of psychoanalytic ideas in psychosis. Now, I can talk to biological psychiatrists. I'm quite happy to, and have done for the past 40 years. In this area, it's actually been very difficult to have the sort of discussion that you're advocating, you know, without getting sort of railroaded and told we're bigots. I've been called a Christian, right-wing. I haven't been to church since I was about 11. I've always voted sort of Liberal Democrat. But I'm like the pariah. So I think this is a starting point, which is about our book, which is a particular approach. There are other approaches out there, and there will go on being other approaches out there. We're not trying to convert the whole world to the Evans doctrine. You know, people can have a look at the book if they're interested and make up their own minds. For us, we would like to think, it might be different in your country. We would like to think there is thorough psychological examination before a medical approach. That is not what was happening in our view sufficiently. There are some clinicians at GIDS who do a thorough psychological examination, but there were also kids who were sort of passed through to puberty blockers after 2, 3, 4 occasions. For me, that is unethical.
Good answer. Coming out as a Lib Dem, a bit disturbing there, but
sorry about that, David.
We don't talk about that. But,
She's Labour.
But the other thing is, I just was going to pick up on something you said, Milton, as well, about sort of the sides, and it's something journalists keep asking me, and I think it's a shame, really, because of course there are such strong feelings provoked in the area, and there are, you know, certainly groups that are absolutely at the two sort of ends, if you like. And again, really, in this particular area, of course, we're presenting our views and our experiences and our thoughts today, but it's not about taking a side. I think we'd like to think we're on the side of our patients, which is, you know, that we're trying to help them find themselves, whatever route they're going and where they're going. So I really want to kind of dispel that sort of idea that this is a side. Now, I know you could say, oh, but you're saying, you know, you don't believe in gender ideology, let's say, or you don't believe that people should be affirmed immediately. Well, no, because we have a particular view that we're trying to think about with everyone today, you know, that's our clinical experience. You know, in the end, I think eventually things will evolve in the same way that lobotomies were very popular in the 50s. You know, I don't think anyone practices them now. Yeah. Who knows where this will go? Maybe they'll find something on a brain scan one day that tells us what we need to know about transgender people. I doubt it. I think this will be like many other areas of sort of psychological medicine or therapy, which is that you understand people as a whole, and people bring symptoms and ideas and a way of operating in their minds that then we're just going to try and open it up, and that's really what we're trying to do today.
Yeah.
You know, I hope people can hear that in it sort of, you know, anyway.
Any more waves? Anybody waving? I'll go on with the questions. Gary Powell, can I ask, please, what is the risk of children who are gay or lesbian being misdiagnosed as gender dysphoric? And what proportion of children you treated who presented as gender dysphoric also indicated they were same-sex attracted? In all this category, what was the incidence of homophobia among the parents? And to what extent is there evidence that homophobic parents want a trans son or daughter, maybe unconsciously, not consciously, rather than a gay or lesbian son or daughter? It's so true about many of the people I've seen. So carry on.
There's a lot there. So I'll try and come back. Remind me, David, if I've missed some on the list out. The first thing to say is that certainly here in the UK, the statistic keeping at the Tavistock is so poor that when the judges at the judicial review asked them on the first day of the trial, how many of your young children have autism? They couldn't answer it that day. When they came back the next day, the judge had requested them to supply that information. They still couldn't supply it. And they are the UK expert service, allegedly, in this area. So they don't know how many of their young children are on the autism spectrum. And I would suggest they wouldn't have the statistics for how many of them have a homosexual orientation. And what were some of the other questions there, David? But you'll understand that what I'm saying is that statistics and data are so poorly kept in this area that people will trot them out. I don't know the answer to that. What I do know is that when you work with the children, and it's just happened to me recently, I'm working with another colleague, a child psychoanalyst, and we saw a young child twice, and by the second, clearly presenting as transgender identity, you know, absolutely certain, wanted a name change. Actually, within 2 sessions, and this rarely happens, but within 2 sessions, realised that actually she was furious about something and that she felt she was potentially gay and was really just struggling with it. Now, that might change again, but it will tell you kind of the way in which these things move around and how it's so difficult to know who's homosexual, who's transgender, or who will become transitioned.
It was certainly one of the things that Dave Bell picked up in his report when he interviewed the staff, that there was a lot of homophobia in the families. But I think our sort of cautionary note is we see kids and actually they're struggling with all sorts of things. That is one of the issues. It's not the only issue. So, you know, again, one doesn't want to get down a sort of tram line. It's an important factor of many different factors.
Yes, thank you. Susan, you wanted to interject something?
Yes, actually, I had a message from Ken Zucker who said, did I want to talk about the outcomes of parents in our group, of the young people, of parents in our group? And the short answer, I think, is that it's too early to say, because Bayswater support groups really only been going since 2019 and the numbers are growing very fast. But the second thing I wanted to say is it struck me for a long time that actually parents who don't affirm seem to be to provide a very obvious opportunity for a control group for research studies, just to see what happens with a different kind of environment. And my third thing is just a sort of an impression. I would say there are all sorts of different trajectories, courses, outcomes described by parents, young people who over lockdown, away from school, seemed to be much less interested in gender, became interested in other things, pronouns change backwards and forwards. There are people who want a particular pronoun at school but have a different pronoun at home. Young people who change their schools, their clothes in different situations. So I think just the kind of complexity of gender expression and gender identity which shifts around is what we're seeing. And certainly there are parents whose young people have desisted, but we're not kind of, I don't think it would work if, as a parent group, if we were, you know, we're trying to get our children to desist. We're trying to provide a kind of supportive environment in which people can be who they want to be without being channeled or forced.
Absolutely. I think that's right. And one's got an open mind about what the outcome might be. But I was just thinking that Sue and I are seeing a lot of parents at the moment. First of all, they're relieved. Secondly, they get into a sort of, do they get into a battle with their child, or do they back off? They don't know what to do. They're sort of caught in the teeth of a dilemma. They don't want to lose their child, and there's talks of threats of suicide and one thing and another, but they don't want to sort of completely go along with it, and they don't know how to sort of move, and in a way, or where to position themselves. Now, in a way, what Sue and I often do is try to sort of open things out that often one gets stuck down a tram line, and one's often thinking about the things that are not expressed, which are offset.
Yeah.
What's not in the sort of, this is all about gender, we either go along or we don't, what's going on elsewhere? What are the unseen forces, which sometimes as a parent, when you get really worried and preoccupied, you tend to get a bit narrow in response to your child's narrow preoccupations. And often that's the point, is to take away from, the worries that are not voiced, that are not seen, and that one of the things that we often see is that kids are really struggling with who they are and where they belong in the family and where they belong in society. They're frequently quite anxious, socially isolated, so that can be very helpful to parents, but we don't know what the outcome's going to be, but the parents suddenly think, oh, thank you, that's helped. Another way of thinking about things, not to be constantly in a battle. Yeah.
A message from Kitty in Australia. We've had quite a few people from Australia asking this question. I'm wondering how therapy can help autistic youngsters, given their concrete thinking, rigidity, and relative emotional immaturity. My understanding is that traditional insight-oriented therapy tends not to be helpful for people who are autistic, even as adults. Also, can you speak about boys as well as girls? Well, I think we have been, but people on the autistic spectrum. And so I'm a bit worried about this question because I do a lot of work with whistleblowers, and somebody's tried to make the connection recently between whistleblowing and autism, which I think is completely fallacious. But
yeah, I mean, the sort of difficulty relating is something that we're going to come on and talk a lot about
in more depth this afternoon.
And it does present like talking about the limitations of of your approach. It is a challenge working psychoanalytically, because psychoanalytically we're interested in the symbolic and the emotional, and that often the kids that present are very concrete in the way they think. In fact, they often present as finding their minds quite dangerous. And so we're having to explore different ways of trying to work with kids who are sort of, this is a new landscape for them that they feel rather uncomfortable about. But as I say, and we don't know, there are limits to our approach. Certainly, I think thinking about it from a psychoanalytic point of view can be helpful, whether or not the psychoanalytic approaches actually help the child or the family. Sometimes it helps to have a model for thinking about what might be going on, even though you sort of feel you're up against it clinically. But we'll talk more about that in the next session.
Yeah. I mean, it's so difficult as an analyst. Like at the Portman Clinic, I saw many transgender people, some transitioned, some didn't. I didn't have a great idea about what I didn't mind what they did. Okay. If I sit opposite somebody and their first thing in the session is, look, all I want to do is get rid of my old man, a euphemism for his penis. Okay. And I said, well, you're seeing a psychoanalyst, so as a psychoanalyst, your old man could also refer to your father. So I asked him the age-old question, when did you last see your father? So I haven't seen him since I was born. He cut me off completely. Okay. As an analyst, you can't avoid that. So to think about this, it's a very concrete communication about something deeply painful that's being played out on the body, And I don't particularly want to go down that road. When I challenged him on that and got him to think about it, he accused me of trying to mutilate his mind with my thinking. I want to mutilate my body, that's my responsibility. However, he stayed in therapy for 9 years. Okay. And he decided not to transition in the end.
Yeah.
And it was extraordinary because he was in a job, something like teaching, I won't say what it was. And he was gradually going to turn from being a man into a woman in front of his class. And unconsciously, he began to understand that part of that was his wish to do to the children in the class what he felt his father had done to him, a gradual reduction of masculinity, a disappearance in some ways, okay, and turning into what is a woman, you know. And it was really useful for him to understand that. If he'd gone on to have a transition after that would be his business, okay? But he wanted to think about it, even though he attacked me when I did tell him what I thought about it. He didn't like it.
And actually, I was contacted by someone. I just got a very nice email actually from someone who had transitioned a few years ago, who just said to me, you know, I'm glad you speak about the therapy in this way because, you know, I was glad that I had it. I've transitioned, but I'm really glad for the psychological work that I did before I did so. I think it helped me in my life. And that's an important thing, I think, you know, to hear.
Absolutely.
I just wanted to come back to one point that Susan made. She's often said about psychoanalytic approaches. For me, what I'm passionate about is good mental health. I happen to be a psychoanalytic practitioner who thinks it's a helpful way of thinking, but actually I'm primarily, hopefully, a good psychiatric practitioner. But I think it's a very important point that you make, Susan, and sometimes in psychoanalysis, psychoanalytic ways of thinking, we can just focus down on the psychopathology. Actually, that's bad psychoanalytic work, because sometimes, in a way, what you've got to bring to the fore is some of the other aspects of the personality which are not so visible, and that they need to be brought in. I mean, we've all got to struggle with our strengths and weaknesses, our deficits and one thing and another. That's the you know, we've all got to come to terms with ourselves, warts and all. And in a way, good psychoanalytic practice is about that. It's not just focusing on the pathology. It is saying how there might be some difficulties, but what other things can you bring into to your life and to the party?
Yeah. A couple of questions, a couple of statements, really. Lisa Blakemore, a number of adult D-trans women are only just realizing that they are autistic. As a psychologist specializing in autism, I am concerned that many young girls attending gender clinics are not assessed for autism. And another one from Alison Clayson. I just want to say, I think the setup here where participants can speak and ask questions is a very open one. Good, that's what we want to create. I think the organizers are brave. I compare it to another recent Zoom conference that was pro-medical affirmation where everyone was silenced and no one could directly ask questions. I think Marcus and Sue are also open to thinking despite standing strongly for their approach, admitting uncertainty of their approach, healthy compared to what seems a worrying certainty of affirmation clinicians. Okay. There's some affirmation for you there. So, yeah.
Oh, well, that's just, I've just remembered something you said in that question about 3 questions ago. It was about the attitudes of parents, actually, which was another important point. That, again, I think parents, in the same way that we're saying all these children, but I think, where did I get to? But you know, parents again often come to this. It's something, it can be really shocking to them. It may be something that they've been expecting since their kid was 3. You know, that each parent's experience of their child is unique. But the important thing, again, and we'll talk about a bit, is that the family dynamic is important. And that, again, you see, is why if all you do is affirm a child, but not really understand how the parents are with their child or what their attitudes are towards the child. And certainly in certain cultures, you know, we know that homosexuality is not acceptable. You know, so but that's not that all parents are homophobic, you know, who affirm it. It's again, it's so important to make an assessment and to understand more holistically what's going on in the family, isn't it? That there may be all sorts of things at play in the dynamics of the family that have caused the child to feel a certain way and have certain beliefs.
I was going to say about the autism question, very important, is that Ginsberg, Sue contacted Ginsberg. Do you want to say
no,
that?
Well, go on, you go.
Well, so Ginsberg is the lead professor in autism, I think, more or less in the world. He was one of the witnesses in the case. and he talked about the way that the autistic individual who likes black and white thinking and is trying to control their sort of emotional environment can be very drawn to the idea that if you can get rid of a disturbing aspect of yourself. And so I'm just responding to the person who made the comments, the psychologist David, who talked about the need to assess autism. It's extremely important. You can be pulled into this way of thinking if you think sexuality is disturbing and we want to put a lid on it, and I will have much more control over my mind and my relationships if only I've got a lid on sexuality. And yeah, certainly. And the fact that the Tavistock didn't collect statistics for the number of kids who had autism. That was the question, as Sue mentioned, that was asked in the trial. Where are the statistics? They didn't collect them.
I'm just going to make an aside here. When I first met Marcus, well, actually 6 months into our dating history, he called me by his previous girlfriend's name. He's managed to cite Lord Alderdice instead of Lord Carlisle. It's Professor Gilbert.
Gilbert, sorry.
I'm dyslexic. So.
But Professor Gilbert very kindly agreed to.
I said Ginsberg, and she went, "Who are you talking about?"
I recognise the problem.
That's why I said no.
She's
you
dementing.
said, because I was thinking I don't know who Ginsberg is. It's Gilbert.
Right.
All right, Mark. Adam Meller. The topic seems so polarised, and I'm wondering what people's thoughts are about why there are such strong opposing views. It seems to me there might be a parallel process within ourselves regarding being male or female, one or the other. Question mark. Good question.
Well, we all do have struggles with our identity and our sexuality. You know, we're not. We know the one thing, we're a bit feminine, we're a bit masculine. We've got relationships with mother, with father. You know, we are, and there are rivalries between the sexes as well. You know, who gets the better deal? You know. The woman has to carry the children, and you know, so these things they're ongoing issues for all of us and for society about the sort of relationship within ourselves and within society between the sexes, and that's partly what we've got to come to terms with as individuals, and you know, in our relationships, and
Jackie Granger, more a statement than a question to the previous speaker a little while ago, probably Milton, I think. I'm in attendance and don't feel there are only people here from one side. I have worked in the LGBT community and with trans people for the last 20 years as a psychotherapist. I know some people will benefit from transition, both social and medical, and some will not. A cautious approach is the neutral one, and isn't that the essence of working therapeutically with clients? I look forward to hearing everyone's views. Yeah.
Helpful comment.
Great.
And could I ask, this is from Chris Connolly, could I ask from Sue and Marcus's experience, is there an ethnicity component involved in those presenting at GIDS? GIDS? Interesting question.
So it is an interesting. I don't know exactly the answer now because I'm not there anymore. Susan, I don't know if you're better at the research on this. My impression when I was there was that it was mostly, and I hate these labels, but in the UK it was mostly more white middle class families that seemed to come. But that could just be in the same way that it's not very easy for members of the ethnic minority communities to access psychotherapy, full stop. You know, that it could be just that white middle classes get better access to healthcare. But Susan, do you have any research data at your fingertips?
I don't think I do. It would just be impressions and would be the same as you. But I mean, there are other people who will know, but I don't.
And I think certainly Abigail Schreier in her book it said something similar. I think that tended to be. And of course, you know, I'm sure there are. I think actually Stella, who's listening in, I remember in her documentary she made for Channel 4. Stella, am I right in thinking that you interviewed an ethnic minority child? I don't exactly remember where they were from, but is that right?
Yeah, two ethnic minorities were in the film, and they were both born female and transition to male. But I agree as well, though, in my experience, it's mostly a white middle class phenomenon, very much reflected on the kind of anorexia and the self-harming kind of pattern.
So we're going to bring this to an end now, and we'll all come back after a cup of tea at 11:30. So do come back for the second pot, which is a model for understanding gender dysphoria. And we'll have Kirsty Entwistle and Stella O'Malley as well. So do join us at 11:30. And thank you, everybody, for a really good discussion and a really good beginning. Thank you very much.